Our first speaker is Justin Moyers, who's here, who has joined us over the last couple of years and worked to build our immunotherapeutic program, cellular, CAR T-TIL program. Dr. Moyers comes from a huge background of drug development. I look forward to hearing his thoughts, and welcome and take the cue.
Thanks, Dr. Pierre. Thanks, Dr. So I'm going to talk about kind of set the stage for all the other speakers. So I'm going to call this our Melanoma 101 talk. We're going to review the initial first line and second line treatments that patients with metastatic melanoma may receive as part of their care. So quick agenda. So we'll talk about the current first line treatments, and we have some long-term updates that have come out over the last basically year on several of these. Then talk about some selected second line options in immunotherapy, targeted therapies, and cell therapy. If you've attended any melanoma talk in the last several years, you'll see this awesome timeline of drugs that have been approved. Here's the most recent one with the update of lifileucel, the cell therapy last year. And so, we know that there were few approvals until 2011. And since then, there's just been a number of approvals in immunotherapies and targeted therapies. First up, there's the KEYNOTE-006 study. This was the trial that established pembrolizumab as a checkpoint inhibitor with good efficacy in metastatic melanoma. They compared pembrolizumab, which is anti-PD-1, to ipilimumab, which is anti-CTLA-4. But this is the 10-year follow-up. So you can see out at 10 years now, we see that there's long-term survivors of metastatic melanoma, and that tail really doesn't change much after 6 years. So people are surviving with melanoma on single-agent checkpoint inhibitors for a decade. The biggest trial one of the biggest trials that changed everything was a checkpoint 067, where this is where we found out that dual checkpoint inhibitors work better than single-agent checkpoint inhibitors for untreated metastatic melanoma. And so it was 3 arms, either people given nivolumab, also known as Opdivo, or nivolumab plus ipilimumab, or ipilimumab alone. So it was 3 different arms of those two drugs in 3 different permutations. And the initial trials, we saw that the progression-free survival, so the time it took from the cancer to grow or not respond to the immunotherapy, was longest in the double combination. So these data have been ongoing. They've been following patients for now 10 years. So this is the last update, just published a couple months ago for the 10-year outcomes of this data. And so what we see is that after 5 years, not a significant change too much in people having recurrences or deaths after that time. But I think the interesting thing to point out is that if we look at the melanoma-specific survival, when you're out at 10 years, people start to, have other illnesses, diabetes, heart disease, other cancers. They can, affect their lifespans. And so if you look at melanoma-specific survival, meaning people who died from melanoma specifically, there is not significant changes for any 3 of the arms between that 5-year and 10 years. So still over half the people are, living with remissions for their melanoma at 10 years if they got the double checkpoint inhibitors. Very great stuff. And one of the also interesting things is if you were without melanoma 3 years, so surviving and not having your melanoma progress or grow, at 3 years, few people had additional recurrences after that time period at 10 years. So most of the people, if they're having recurrences, are happening in that first 3 years. So that's an encouraging thing that we can tell our patients. If you're doing really well at 3 years, we think your melanoma is going to be under very good control based on this data. Other interesting part to kind of pull out of this big data, this landmark trial, is that depending on how much the tumor shrank on any of these three arms, that correlates with how well you'll have remission from your melanoma. So the more shrinkage, more likelihood that the melanoma will remain in control at 10 years even. Also interesting, one of the things we always point out is there's side effects with these immunotherapies, but it's not a horrible thing to see some side effects with immunotherapies, as we see that if you have some side effects with immunotherapies, you're likely to have a better response than if you don't have any side effects at all. So we see that people who had some side effects, their survival, their remission rates are much higher than if you did not have side effects. So moving on, the other combination is anti-PD-1, which is nivolumab plus relatlimab anti-LAG-3. This is the Relativity 047. This combination was approved within the last several years as well. This trial looked at previously untreated metastatic melanomas. They compared single-agent PD-1 versus this dual checkpoint inhibition with LAG-3 and nivolumab. What they found out was that the progression-free survival or time it took the melanoma to grow, if you are on the combination, was longer than if you had just a single drug. So we found out that this drug combination seemed to be better than the single drug alone as well. Correlated to people surviving with their melanoma longer as well, if they got the combination nivolumab plus relatlimab. So moving on, the other first-line category to think about is first-line targeted therapies. What are targeted therapies? So in melanomas or any cancer in general, there can be mutations that form to cause the cancer to have unregulated growth. 50% of melanomas of the skin have a BRAF mutation. There's three different classes of BRAF mutations. The ones that we care the most about are these BRAF V600E. You'll see this information on your next-generation sequencing, so the DNA testing of your tumor. We call this class 1. They are the ones that are activated by this mutation and cause unregulated growth. These are the mutations that are most responsive to the therapies that we have right now approved. So this landmark study compared two drugs that act on the BRAF mutation, dabrafenib and trametinib, in melanoma. And they compared it to, it was a phase 3 trial, so a large trial with 700 patients. They compared the combination dabrafenib and trametinib versus the old first-line therapy for this, which was vemurafenib. What they saw was that people's tumors took longer to grow on the combination compared to the single-agent BRAF inhibitor, and people live longer with this combination. Complete response happened in 47%, so complete shrinkage of the tumors, at least temporarily, happened in nearly half the people with the combination BRAF inhibitors, whereas only 27, so only about a quarter with the single-agent BRAF inhibitors. There's multiple trials that have been looked at this combination. They combined them to find out that at 2 years with this combination, half the people were alive in their melanoma under control, basically. And if we separate out those responses for what was the best tumor response you had, so if you had a complete response, meaning the tumor shrunk to nothing, or if you had a partial response, or meaning that the tumor shrunk a little bit, or if you had stable disease, meaning the tumors didn't grow, but they didn't shrink too much either. The best responses, the best temporary tumor shrinkages happened in those who had complete response at the beginning. So we talked about the dabrafenib and trametinib. There's actually two other sets of combinations basically made by different drug companies: vemurafenib, cobimetinib, and encorafenib and binimetinib. And they each have their own different set of side effects. So the pink are the dabrafenib and trametinib, the reddish are the vemurafenib and cobimetinib, and the orange are the encorafenib and binimetinib. You can see that if you break it down in side effects, different ones have different side effects. So the Tram doesn't have much of the eye side effects, but it has more fever. We tend to use, I think most of us, encorafenib and binimetinib. It seems to be the best tolerated, but any of these three can have different side effects for the individual. This moves on to, so we talked about immunotherapies and targeted therapies. Which one do we choose for first? Because we can only get one first. And so they ran a trial called the DREAM-seq trial to answer this question. All of the patients with BRAF melanomas were randomized either get immunotherapy first or get the targeted therapy first. And then once the cancer grew, they would switch over to the other treatment. We found out that it does matter. We found out that giving the immunotherapy first allowed more people to have remissions and control their tumors compared to those who got the targeted therapy. So this really settled the question. We also see that about 46% of people, at least in this trial, had tumor shrinkages with immunotherapy compared to only 43% the targeted therapy. And then importantly, in the second line, those who had the targeted therapy first, the immunotherapy just didn't respond as well. Whereas if you had the immunotherapy first, the targeted therapy still responded, nearly as well in the second line setting. Next question, which of those immunotherapy combinations should we pick? So we know now immunotherapy is the best to go forward first. Which one do we pick? So this graph I really love shows grade 3 and 4 side effects, or those serious side effects that can lead to treatment or hospitalization on the y-axis going up and down. And then on the x-axis going sideways, we see how long they worked for. And you can see that the nivo-ipi has the most side effects, but also works the best. Whereas nivo-rela is pretty close. It works nearly as good as the combination of nivo and ipi, but doesn't have nearly the amount of side effect. Each of the single agent checkpoints have less side effects and also less efficacy. So that naturally leads to the next question. Why not use all three at the same time? We talked about nivo and ipi and nivo and rela. Why not combine the three? So this is an interesting study. This is not yet standard, but I thought I include this. Our colleague over at Italy presented a trial of Relativity 048 where they combined nivo, ipilimumab, and relatlimab. And they see that in this small group, there's only 46 patients in this trial, but in the other ones we saw 100. We see that people are getting remissions, having tumor shrinkage at a high rate with this combination. So hopefully more to come on this combination. After first-line therapies, so what happens if the tumors don't or start to grow after the first-line therapies are given? This is our NCCN guidelines. We have a whole list of things that we can consider based on BRAF mutation or not. Most of these are immunotherapies. We will go over a couple of them. Why do we think about immunotherapy combinations? So immunotherapy has allowed field of oncology to change. We have even durable cures like we talked about. However, some people's tumors are cold. They don't respond to the immunotherapy. So these combinations hopefully can resist checkpoint blockade due to several different modes by changing the cytokines, by changing how the tumors present these antigens that allow the immune system to respond, and then also just causing death of the T cells that are regulating the immune response. And therefore, new therapies to try to overcome these obstacles that are hindrances to immunotherapies working well for all melanoma patients. These are some of the targets that we looked at. So, PD-1, we've talked about this, the pembrolizumab, nivolumab, CTLA-4, that's ipilimumab. And then what are the investigational ones? So, or not investigational, the newer ones, LAG-3, we have the relatlimab over on the right. There's trials going on in pretty much all of the other ones that were listed here. We have seen trials in BTLA4, 40, 41BB. So what are some combinations that we are in the guidelines or people use? One of the ones that I like the most is, it's not approved, but we have phase 2 evidence, is the LEAP-004 study using a drug called lymphatinib, brain-enabling lymphedema, plus pembrolizumab or Keytruda for melanoma after PD-1 drugs did not work. And how does this work? So we've talked a little bit about how Keytruda works. It activates the T cells to try to fight your melanoma. How does lymphedema work? It's something called a multi-tyrosine kinase inhibitor. It blocks several different proteins growing. So the thought is that it can disrupt blood vessels and allow for the immune system to target the cancer. This is a single-arm study, meaning that they didn't compare it to anything. Everybody got the same drugs. This waterfall plot shows tumor growth if the bars are going up, shows tumor shrinkage if the bars are going down. So we see that 65% of patients on this combination had some sort of shrinkage. There's an somewhat arbitrary threshold set at 30% shrinkage to call it verifiable shrinkage, and about 21% of patients got. So pretty good combination to keep things stable for many patients. If it worked for patients, the duration it worked was about 8 months. Another combination we sometimes use after PD-1 therapies is something called TVEC. TVEC, I put the infographic here on the right. How it works is it's a virus, it's a modified herpes virus that's injected into the tumor itself. It then uses the tumor as a host to grow, and it releases these antigens, releases bits of itself upon breakage, which is attracted to by the immune cells, called dendritic cells in this case, and forms a response to attack the tumor. So this is a kind of causes inflammation of the tumor, allows the immune system to attack the cancer. We call these alkylytic viruses. So this trial looked at taking TVEC plus pembrolizumab or placebo plus pembrolizumab to see how well this combination worked in the first-line setting. What we saw is that if you compare the two, first-line pembro versus pembro plus the TVEC, we saw a slight improvement in how many patients were having tumor shrinkage, but it did not reach statistical significance. So it wasn't for certain without chance that this combination was better than the single agent. Nonetheless, it's something we consider in the second-line therapy, especially if patients who have tumors we can feel and we can poke a needle into put that modified oncolytic virus in. That also brings us to this next phase. So the next generation, is something called RP1. It's another herpes virus that's modified. Works the same way. It's injected to tumor cells, causes infiltration, which activates these T cells. But the interesting thing about this is that unlike TVEC, where we've mostly only seen the tumors themselves that are injected shrinking, we're seeing tumors outside of that injected area shrink as well. And so we call this a spider plot. The lines start at the middle, and then like legs of the spider. If they go down, that's shrinkage of tumor. If they go up, then that's growth of tumor. The red ones are the ones that tumors are injected. The blue ones are tumors elsewhere. And so you see not only the red injected tumors decreasing in size, but many of the blue non-injected tumors are shrinking in size as well. This is one patient's example that was presented by Dr. Walling at ASCO. Injected tumor, the forehead, but also having shrinkage in the liver tumor. Very cool stuff. So there's, at ESMO this last year, preliminary data for some of this was presented. We're seeing responses again in injected and non-injected lesions. There's ongoing trials to further take this information or this drug to further phase trials. Next, targeted therapy. So what after BRAF and MEK inhibitors? What else is there? So one thing that's based on an older study in 2017 from the Lancet if people have NRAS melanomas, there's targeted therapies with binimetinib. This was compared to chemotherapies. This was over a decade ago. And if you use binimetinib, that works better than chemotherapy for NRAS mutations. So still a drug that we can consider if people have NRAS mutations and we don't have other better options for them. We also look at the tumor DNA to look if there's something called fusions. You see on the left, we call these translocations, the other name for them. You see pink and blue chromosomes. They do some handshake and they switch parts, and afterwards they have what's called a translocation. Few melanomas have this. I looked at this from ACRG, has thousands of patient cases of NGSs. Over 90% of melanomas do not have fusions. Fusions are really uncommon. The most common ones are BRAF fusions, ROS, RET, and TRK, now fusions. Why are these important? So these are the needle in the haystack cases. BRAF fusions, there's new drugs that are being developed for these. And there's right now really only single patient or small trial data. For one patient who had a SCAP2 BRAF fusion, they got trametinib, had a response lasting months of tumor shrinkage in their liver. There's also what we call tumor agnostic approvals, meaning no matter what cancer type you have, if you have this mutation, like a TRK fusion, you can get a drug that can shrink the cancer. So in this trial of larotrectinib, which is a TRK fusion drug, if you had a TRK fusion, most of the time your cancer shrunk. And if you look at this list of 30 odd patients or so, the green bars are melanoma. So a couple melanomas with TRK fusions had significant shrinkage, one of which had complete shrink to their tumors if you had this rare mutation. ROS fusions, similarly, a patient with melanoma got crizotinib on a case report, and it took their melanoma to shrink it basically down to nothing, at least temporarily. Had 2 years for this patient of complete tumor shrinkage. Another one, the last one that has a tumor agnostic approval is pralsetinib in RET positive cancers. Another uncommon mutation in melanoma, but something we look for in the standard NGS panel. Lastly, going to cellular therapies. This is an infographic I created to kind of explain patients how this happens. So patients will have a tumor. An excellent surgeon like Dr. Ferries will take it out. They will isolate the TILs from the tumor tissue in the lab. They will expand or modify these lymphocytes that are extracted from the tumor tissue, and they'll make this TIL product. This can take weeks to months. And then they'll come into the hospital or clinic, get 3 to 5 days of what we call lymphodepleting chemotherapy to decrease the amount of lymphocytes, which are part of the white blood cells, in the patient's bloodstream, allowing room for the TILs to be infused. The TILs are then infused, and then we activate the immune system by using up to 6 doses of something called interleukin-2, which is a synthetic version of a cytokine or a inflammatory protein in your bloodstream. How is this process developed, or how is it approved? So there's a landmark trial that of TIL, so tumor infiltrating lymphocyte therapy, or using anti-CTLA-4 ipilimumab, done by the Dutch in advanced melanoma. They looked at comparing these two and second-line therapy. They found out that people had more remissions, lived longer if they got the TILs compared to if they got ipilimumab alone in this trial. You can see on the right, ipilimumab had far more growth than the TILs on the top. The U.S. approval was based on a composition of several trials with the Iovance product known as lifileucel. Overall response rate was 31% in these refractory patients who got TIL. This has led to the FDA approval of the first cellular therapy in solid tumors. And what are the side effects of this? can mostly relate to lymphodepleting chemotherapy, having your blood counts be lowered, chills, anemia, more things that are causing your immune system to be responsive, fatigue, and some other kind of immune-related side. So this is just a game changer for us. Many trials going on in this that are using TILs in combination with other drugs, such as checkpoint inhibitors, radiation, targeted therapies, vaccines, and then also just modifying the TILs in some manner. This is the updated results of this. We see considerable tumor shrinkage from part of that Iovance trial. This has led to a next step where they're trying to compare pembrolizumab alone versus the TIL plus pembrolizumab to see how much significant improvement we can get for using TILs in the first-line treatment. So will TILs be a first-line treatment? That's what this trial is trying to share. And that ends kind of an overview of our Melanoma 101 to as it serves as a basis for everybody else to expound upon.